So first, let us see what you mean by neuroendocrine tumors. So in terms of origin of neuroendocrine tumor, it originated from neuroendocrine cells. As name suggests, it originated from nerve cells and endocrine cells. But characteristically, the neuroendocrine cells which produces neuroendocrine tumor don't have any axon or nerve terminals. The electrical signals from the nervous system can be converted into hormonal signals. Why this neuroendocrine tumor developed? Our neuroendocrine cells develop changes, that is the mutation in their DNA, and the DNA inside a cell contains the instructions that tell the cell what to do. And both these changes tell the neuroendocrine cells to multiply rapidly and form a tumor. Neuroendocrine tumor constitute only 0.5% of all malignant condition and 2% of all malignant tumor of the gastrointestinal tract. And these tumors are more prevalent in female, and in terms of ratio, male is to female ratio is 2.5 is to 1. Related to site of neuroendocrine tumor, most commonly NET is present in the gastrointestinal tract followed by lungs, and the gastrointestinal tract neuroendocrine tumor and lung neuroendocrine tumor constitute carcinoid tumor in more than 80% cases. Some neuroendocrine tumors start in the pancreas, adrenal gland, and present as a pheochromocytoma or paraganglioma. And facts of gastrointestinal neuroendocrine tumor are about 40% neuroendocrine tumor are hormone secreting, and most neuroendocrine tumor are slow growing, about 20% associated with MAN1 syndrome and neurofibromatosis type 1. Classification of GI NET as per WHO, which was revised in year 2017, is based primarily on mitotic index and Ki67 index. Index like this: if the level of Ki67 index is less than 3 and mitotic index is less than 2, this is called neuroendocrine tumor grade 1, that is the G1. And if the level of Ki67 index is in the range of 3 to 20% and mitotic index is in range of 2 to 20, then the grade is called grade 2. And if the level of Ki67 as well as mitotic index is more than 20, then the grading is neuroendocrine tumor grade 3 or G3. Now come to learn about biology of GI NET. Cytoplasmic dense core granules contains 3 important biomarkers, which are chromogranin A, also known as CGA, synaptophysin, and neuron-specific enolase, and this can be abbreviated as NSE. So CGA and synaptophysin are necessary for diagnostic confirmation, and proliferative index of Ki67 and mitotic index are necessary for prognostic information. Serum CGA is raised in both non-functioning and functioning neuroendocrine tumor. So, my dear student, please remember this biomarker serum CGA. This is important because it's raised in both functional as well as non-functional neuroendocrine tumor. Serum CGA is the most commonly used biomarker to assess the disease burden and monitor the treatment. Now come to know the different types of GI NETs, which are Agastic NETs, small intestinal NETs, duodenal NETs, jejunal-ileal NETs, appendicular NETs, colonic NETs, and rectal NETs. So now for gastric neuroendocrine tumor. Most of the gastric neuroendocrine tumor develop from intrachromaffin-like cells. This cells is also called as ECL cells. GNET constitutes 7 to 8% of all neuroendocrine tumor, and this is classically categorized in 4 types: type 1, 2, 3, and 4. GNAT type 1 is the most common type of GNAT. It occurs in response to hypergastrinemia in the setting of achlorhydria, where gastric pH is usually more than 7. Hypergastrinemia leads to ECL cell hyperplasia and promotes the formation of GNAT. Most of the time, it diagnosed incidentally. Endoscopically, GNAT type 1 appears as a smooth, rounded, sub-centimeter, subepithelial, multiple polypoid lesion. For the GNAT type 1, endoscopic ultrasonography is also helpful in finding out locate metastatic to lymph nodes, which is present in 5% cases. CT or MRI should be done to rule out any distant metastasis, and the incidence of distant metastasis is reported in 2% of cases. Histologically, most GNAT are positive for CGA, non-neuron-specific enolase, and vesicular monoamine transporter 2. Treatment for GNAT type 1 is endoscopic resection either by polypectomy or EMR or EST. EMR is endoscopic mucosal resection and EST is endoscopic submucosal dissection. And this treatment, polypectomy, EMR, and EST, is the treatment of choice if the lesions are not extensive. But if the size of the lesion is more than 1 centimeter, if it's extensive, if it's a multifocal more than 5 centimeter and recurrent in nature, then we need to resect as a wedge resection of the stomach or even a gastric enterectomy. And prognosis is excellent with a 5-year survival of almost 100% in 90 to 95%. One important drug, netazipide, which is a gastrin cholecystokine 2 receptor antagonist, decrease the number and size of type 1 GNAT as well as serum CGA. So netazipide may be useful in case of GNAT type. Now come to learn about GNAT type 2. GNAT type 2 is the least common type of GNAT. It occurs in response to hypergastrinemia in the setting of hyperchlorhydria. Typically, it is associated with Mann-1-Zollinger-Ellison syndrome. Endoscopically, GNAT type 2 appears as a multiple, small polypoidal lesion in the stomach. And you should remember the triad of Zollinger-Ellison syndrome, which are a peptic ulcer, hypersecretion of gastric acid, and gastrin-producing tumor of the pancreas or other tissue that is called gastrinoma. GNAT type 2, histologically, they are generally well-differentiated tumor. It metastasizes to lymph node or other organ, preferably liver, in 10 to 13% of cases. And for treatment, surgical resection of gastrinoma and aggressive gastrectomy can be considered. Yes, somatostatin analog octreotide may be useful. The prognosis is good with a 5-year survival of 70 to 90%. Now come to learn about GNAT type 3. GNAT type 3 is sporadic in nature. It's not familial. It's most commonly occur in a man over the age of 50 years in the presence of normogastrinemia and normal gastric mucosa. So remember here, this type 3 is not like a condition which occur in hypergastrinemia. So type 3, please remember, it occur in the presence of normogastrinemia and normal gastric mucosa. They develop from ECL cell in most cases in the absence of ECL hyperplasia and are not dependent on gastrin. Patients are often asymptomatic because most of the time such tumors remain silent for a longer time. And because of this silent nature, patient may present as a hepatic metastasis like complaint, and hepatic metastasis may be the first symptom, may be the initial presentation in many cases with the GNAT type 3. Endoscopically, GNAT type 3 appears as a large, solitary, polypoid tumor arising from the gastric body fundus or gastric antrum. Histologically, they are aggressive with high potential for local and distant metastasis. In fact, in more than 50% of cases, regardless of their size, treatment of non-metastatic type 3 GNAT is surgical resection, partial or total gastrectomy, and regional lymphadenectomy. And for a metastatic lesion, we can consider octreotide, we can consider systemic chemotherapy, molecular targeted agent, targeted radionucleotide therapies, transarterial chemoembolization, and radiofrequency ablation. Type 3 GNAT carries a worse prognosis with a 5-year survival rate of less than 35%. Now come to learn about GNAT type 4. Most rare of all GNAT, it occurs in a male above the age of 60 years. They are of non-ACL cell origin. Please remember, among all the type 1, 2, 3, 4, type 4 is very unique in this point because unlike other type 1, 2, 3, type 4 are originated from non-ACL cell and gastric independent. And in spite of that, this tumor GNAT type 4 is originated from non-ACL cell and gastric independent, but in 1/3 of cases, there is a chance that you will get hypergastrinemia. So please remember this fact also. Although GNAT type 4 is gastric independent, but in 33% of the cases, hypergastrinemia may be found. Patient may present with dyspepsia, gastrointestinal bleed, iron deficiency, anemia, and weight loss. Endoscopically, GNAT type 4 appears as a large polypoidal tumor anywhere in the stomach, and at the time of diagnosis, type 4 GNAT may have already metastasized to the lymph node and liver. You may get the evidence of angioinvasion, lymphoinvasion, and deep wall invasion. Immunohistochemically, CGA may be absent in type 4, but neuron-specific enolase and synaptophysin are strongly expressed. So treatment for a localized type 4 GNAT, partial or total gastrectomy with regional lymphadenectomy followed by adjuvant chemotherapy. Cisplatin-based chemotherapy is offered as the first-line treatment for metastatic type 4 GNAT. FOLFOX and FOLFIRI are considered as second-line treatment option. Prognosis is extremely poor with a mean survival of 6.5 to 14.9 months. Thank you.